Good morning, everybody. I think I will go ahead and start off with questions. Like the previous speaker, I'll primarily be focused on one disease, which is prostate, but I will try to go through the important abstracts in bladder and renal as well. So the first question we have is a 54-year-old male, recently diagnosed with metastatic prostate cancer. And at presentation, his PSA was 14, his Gleason score was 9, 5 plus 4. He had high volume skeletal mets on bone scan. He had a 4 centimeter in size lymph node conglomerate in the retroperitoneum, and he had a 2.3 centimeter in size right hepatic lesion. So what would be your next step? The first choice is liver biopsy and molecular testing of the tumor, or starting treatment with androgen deprivation therapy and docetaxel-based chemotherapy, or starting treatment with ADT, docetaxel, and abiraterone, which is an androgen biosynthesis inhibitor, or starting treatment with ADT and abiraterone, or ordering a flucyclovine-based PET scan. So let's have the responses. Okay. All right, so I think my talk probably wouldn't be a complete waste. Let's go with the next question. Don't know, it seems to be locked there.
Left mouse.
Oh, sorry.
That's okay.
So the next one is on bladder cancer. This is a 66-year-old lady with metastatic transition cell carcinoma. She's treatment naive. She has a creatinine of 1.7. She's had insulin-dependent diabetes for 20 years and also has impaired hearing. So what would be your next step? Treat with gemcitabine and cisplatin, treat with gemcitabine and carboplatin, check the tumor for PD-L1 status, treat with nivolumab, or treat with pembrolizumab. So here we go again. Okay, so I think everybody seems to be doing well here. So the top choice is check the tumor for PD-L1 status. And the last question, that's on kidney cancer. What is your preferred treatment in frontline poor risk clear cell renal cell carcinoma? Is it sunitinib or pazopanib, pembrolizumab plus axitinib, or Lenvima plus everolimus, or Ipi plus Nivo, or Nivo alone? Okay, so I think I made the right choice, focusing on prostate and breezing through kidney and bladder. Okay, all right. So I think the main goals for today are, to briefly go over the epidemiology of prostate cancer, primarily focus on the treatment of metastatic disease, and then go over the new treatments for castrate-resistant prostate cancer, and then end up with some of the recent ASCO abstracts, both on bladder cancer as well as kidney cancer. So this is the total prostate cancer burden in the country right now. It's about 165,000 new cases a year. And I think if you analyze this over the last 10, 15 years, we had gone up tremendously, over 250,000. We've probably kind of reached the bottom. Last year was about 163,000, and from here on it's going to increase slightly. The primary driver of all of this, at least recently, has been the guidance from the U.S. task force that we stopped screening. That happened in 2012, and as a result, the incident rate went down. But what that did was we had a huge increase, or both present as well as projected, in the burden of metastatic prostate cancer. So I think in the pre-PSA era, approximately 40 to 50% of patients at presentation had metastatic prostate cancer. With PSA screening, we dropped down to 2 to 3%. The current burden is about 6%, which if you look at 160,000 new cases is about, in absolute terms, 10,000 new patients a year. And in 2025, this is projected to go up to about 12%, in aggregate about 25,000 new patients a year with metastatic prostate cancer. Now, over the last couple of years, I think there's been some change in screening patterns. So again, this could drop as well, but as the population ages and the prostate cancer incidence goes up, I think it's safe to say we probably will have 20 to 25,000 new patients a year with metastatic prostate cancer, at least over the next decade. And this is just to kind of look at de novo metastatic prostate cancer in different countries. So again, this is a dated slide. So the US was about 3%, Europe was 6%, Latin America was about 10%, and the Asia Pacific region was 60%. And this pretty much reflects, whether or not you screen for prostate cancer or not. Now, just because you detect doesn't mean you necessarily improve cure rates. And again, that's been the biggest debate as to the pros and cons of PSA screening for prostate cancer. So moving on to metastatic prostate cancer, I think I want to focus on high and low volume metastatic disease first, briefly talk about oligometastatic disease. And the only thing I want to mention about node-positive disease is, to date, we don't have a randomized trial in node-positive prostate cancer as to the merits of intensifying systemic therapy or doing maximal local therapy. Most of that data is really based on observational studies or retrospective databases. So moving on to high and low volume metastatic disease, the cornerstone of treatment of metastatic disease is androgen deprivation therapy, and simply defined, it's any treatment that blocks interaction of androgens with the androgen receptor. The three typical ways of doing that have been orchiectomy in the past, and more recently, over the last couple of decades, LHRH agonists as well as LHRH antagonists. And then a fewer percentage of people, especially in the past, used to get estrogens. Combined androgen blockade has gone up and down, and anti-androgen monotherapy is pretty much not used. And again, the main point I want to make here is that all these therapies primarily, they castrate or they primarily knock out the testes, but existing therapies do not adequately suppress adrenal or intratumoral production of androgens, which as the disease progresses or with a heavy metastatic burden is also probably important. So how do we define a good response to androgen deprivation therapy? So this was based on a fairly large Southwest Oncology Group trial of over 1,400 patients, and it turned out that the level of PSA after 7 to 8 months of androgen deprivation therapy is predictive of how somebody is going to respond. So here is the graph from that study, and you could stratify patients into 3 groups: those who dropped their PSA to less than 0.2, and remember this is at 7 months, after initiation of ADT, those where the PSA hovers between 0.2 and 4, and the third group of patients where the PSA never drops to less than 4. And based on this, median survival was either a little over 6 years, close to 4 years, or less than, or just about a year. And I think in study after study in the metastatic setting, following the PSA and seeing what it is at 7 to 8 months, is predictive of what's going to happen in the future. So the first study which looked at intensifying therapy in metastatic disease was the CHARTED study. And essentially here, patients were randomized either to androgen deprivation therapy alone, or in addition to androgen deprivation therapy, they received 6 cycles of docetaxel-based chemotherapy. And based on this study, what was found was, again, you could look at people, in all comers, the median survival was up close to 60 months or 5 years, and ADT alone was just under 4 years. So remember, prior to adding chemotherapy, for the longest time, median survival had hovered around 3 to 4 years, depending on when you treated the patient. And then if you further substratify patients into high volume and low volume, in the high volume group, the difference was 49 versus 32 months, and the median overall survival in the low volume group, or low volume metastatic group, has still not been reached. So based on this study, the guidance has been that in the setting of high volume metastatic disease, it's therapeutically advantageous to add 6 cycles of docetaxel upfront. Once again, I remember I mentioned the PSA of less than 0.2, and again in this study as well, it kind of remained predictive of how somebody was going to do. So 32% of patients in the combined arm dropped their PSA to less than 0.2, as opposed to 20% in the ADT arm alone. And in this study, they also looked at 12 months, and there was a similar kind of disparity at 12 months as well. So once again, just to kind of go home with this, the PSA 0.2, 7 to 8 months after starting therapy is important. So remember we talked about ADT primarily knocking out the testes, but there are other sources of testosterone, primarily from the adrenal, and probably more importantly from the tumor itself, which also foster the disease. And so looking at other ways to block other sources of testosterone, and the one drug that had been approved for that was abiraterone, which is an androgen biosynthesis inhibitor. And what it does is it blocks steroidogenesis fairly early on in the pathway. So remember, all androgen as well as estrogen is derived from cholesterol. And what abiraterone does is it blocks the conversion of this into testosterone fairly early on. So the next study in the metastatic that was done was to evaluate the addition of abiraterone to androgen deprivation therapy in the setting of metastatic disease. So this was the Latitude study, where the high-risk criteria were defined as either a Gleason score of 8 and above, presence of 3 or more lesions on bone scan, and presence of measurable visceral lesions. And to qualify, everybody had to have at least 2 of 3, or 2 of 3s, these criteria. So this was clearly in men who had metastatic disease. So again, this was a randomized study, about 600 patients in each arm, and the primary endpoint was overall survival. And this was reported on last year, and at 3 years, there was a 37% benefit in survival in the combined modality arm. So I guess based on this study, now the 2 equally valid options for metastatic disease upfront are either adding docetaxel or adding abiraterone to androgen deprivation therapy. So far, we don't know whether combining all 3 is a better thing to do. We also don't know, is abiraterone better than docetaxel? And those studies are currently ongoing. There was also about a 53% risk reduction in radiographic progression-free survival, but clearly the more important endpoint here is overall survival. Now, in the UK, at the same time, there was another study going on, which was the Stampede study. And again, the design was very similar. The main reason I bring this up is I think this is really a terrific trial design. So this is a gift that keeps on giving. So in the UK, what they did was in 2005, they actually started developing studies for metastatic prostate cancer and metastatic CRPC. And what they do is, anytime a new therapy becomes available, those are their standard arms. They simply keep on adding treatment to that. And so right now they have like close to 3,000 to 4,000 patients accrued on different arms of the Stampede. And whenever a newer therapy becomes available, all they do is they add another arm on. So this is the Stampede at the time of adding abiraterone. And as you can see, they also have 2 other arms going on, one adding enzalutamide and abiraterone. And once again, the Stampede data pretty much mirrored the data on the Latitude. The one difference here is if you look at their inclusion criteria, they're a little more liberal. Patients could have any of these. They could either have metastatic disease, they could simply just be node positive, or they could have stage 3-4 simply with a higher PSA and a high Gleason grade. And so if you look at the patient characteristics of on the Stampede study, 20% were only node positive, and had no evidence of Mets, and 28% were high Gleason grades, had a high PSA, but they were node negative, and they were also had no evidence of metastasis. So this is a slightly earlier subset, as opposed to Latitude, where each and every one of those patients had evidence of metastatic disease. But be that as may, the Stampede results were identical. Again, there was a 37% improvement in survival in patients who got the standard of care, which was androgen deprivation therapy, along with abiraterone. Now remember, Charted was chemotherapy alone, so there's also chemotherapy alone in addition to ADT arm on Stampede, and again, the data on that, they mirror what we saw on Charted. The big difference again being it probably has a subset of patients who did not have metastasis, only had a high PSA or only had high Gleason grade. So based on Charted and Stampede, adding docetaxel to ADT or adding abiraterone to ADT, they're approved standard of care. There is no guidance over which one is better, and there is no data on combining all three as yet. Okay, so moving on to oligometastatic disease. So this is an intermediate state of cancer spread between localized disease and widespread Mets. And this concept has primarily been pioneered by Ralph Wieselbaum, who's a radiation oncologist at the University of Chicago. And operationally, the way oligometastatic disease is defined is as having 1 to 5 metastases. Now remember, this is based on conventional imaging, and conventional imaging in prostate is a bone scan and a CT of the abdomen and pelvis, and at times a CT of the chest. And the reason to define this subset of patients is because we don't know who are patients who will benefit from prostate-directed therapy in addition to systemic therapy, or who are the patients who require additional systemic therapy, or who are the patients who require metastasis-directed therapy. So to test this concept, the Alliance has just started a new protocol, which is a randomized phase 3 study of standard systemic therapy versus systemic therapy plus definitive therapy. So it's going to be about 1,000 patients with metastatic disease, albeit oligometastatic disease, and they will either get standard systemic therapy to be followed either by surgery or radiation, or get systemic therapy alone. And again, I think this will kind of answer a long-held question that in the setting of oligometastatic disease, does it help to treat the primary tumor or not? But clearly there's more to oligometastatic disease. You have people who are on systemic therapy who have isolated Mets, maybe one in the ribs, one in the pelvis, and the question there would be, is there any benefit to doing metastasis-directed therapy or not? The problem here is that not all oligometastatic disease is the same. I mean, you could do a scan and you can find a couple of spots, and the tip of the iceberg may only be that, or you could be opening up a Pandora's box. Now, to help with this, this is an abstract from ASCO where they looked at the results of a PSMA-based PET. So remember the 2 PET scans which are used in prostate or should be used in prostate if available. One is the flucyclovine PET, because that label is reasonably prostate specific, and the other is the PSMA-based PET. So this study talks about the PSMA-based PET. In aggregate, they looked at about 250 patients between UCSF and UCLA. The median age was 68. The median PSA was 1.9, and over 80% of these patients had a radical prostatectomy, and 34% had Gleason 8 and above. So again, this was not all high-risk disease, so it was a mixed group, and here are the results. So at least on the PET scan, on the PSMA-based PET, if your PSA was even less than 0.5, about half the patients, or a little under half, the PET scans were positive. And as you kind of keep on tracking the PSA and go up, once you reach the PSA of over 5, almost all the patients had a positive PET. Now, if you looked at the positive PETs, they were either in the bone or in the locally in the prostate, surprisingly also in other soft tissues and pelvic nodes, which you kind of expect. Now, I think this is a useful modality, but what we're going to do with this is unclear. Clearly in oligometastatic disease, it can help you define, do you have really a huge iceberg? Should you really be using local therapy in addition to systemic therapy or not? But in other settings, it's not quite clear. So I think the strengths of this study was that it was a prospective study. It is potentially practice-changing, but the weakness is only 51% of the cases where the scans were positive were we able to validate whether they actually had disease or not, and 17% only 17% were done by histopathology. So I think this will probably impact staging, but how it's going to influence treatment is unclear. We have a whole lot of patients right now who have PSA-only disease, be it in the hormone-naive setting or be it in the CRPC setting. And treatment for those is primarily driven by the PSA doubling time. So the notion there being if your PSA is doubling more quickly, you're more likely to develop metastasis, and that may be a group for early intervention. Now, whether this will change when we intervene is as yet unclear. So moving on from oligometastatic disease to CRPC. So this is a cartoon which kind of represents the disease continuum in prostate cancer. I think not too long ago, 6, 7, 8 years ago, once somebody failed ADT, once we had worked through the first generation of anti-androgens, the only thing we had was chemotherapy. But then in the last 7, 8 years, we've had 2 good drugs. One is an AR blocker, enzalutamide, and the other is an androgen biosynthesis inhibitor, abiraterone, which have pretty much changed treatment. Initially, they were used post-chemotherapy. Now they're used pre-chemotherapy. And then there have been other drugs as well. There is sipuleucel-T, there's cabazitaxel, and there's RAD223. And in aggregate, what's happened is once somebody has metastatic castrate-resistant prostate cancer, survival has gone up from about 1 year to 3 to 5 years. Now, part of this could just be stage migration, because if you treat people earlier, all you do is you're treating earlier, so survival is more apparent than real. But part of this, at least, is felt to be real because of these newer drugs that are available. So why does one develop castrate-resistant prostate cancer? So once again, castrate-resistant prostate cancer is simply defined as progressive disease despite castrate testosterone levels. It really doesn't factor in increased androgen biosynthesis from the tumors, from metastasis, and another mechanism of gaining more recognition is that the enzymes of steroidogenesis, at least in some men, can be upregulated 10 to 15-fold. So although your substrate doesn't change, the end product changes, here it being dihydrotestosterone, because of upregulated enzymes of steroidogenesis. And then obviously the other one is persistent androgen receptor signaling. But I think the one thing unique about prostate cancer is in the majority of men, despite androgen biosynthesis inhibition, despite androgen receptor blockade, the primary thing that still fuels a tumor is signaling through the androgen receptor. So that's one thing which seldom ever disappears. So the 2 novel hormonal agents, which I already alluded to, one is abiraterone, which is an androgen biosynthesis inhibitor, and the other is enzalutamide, which is an AR blocker. And this is just a summary of all the recent studies that have been done in CRPC, which led to a survival benefit, and they're kind of just here, summarized here as a reference. Moving on to recent advances in CRPC, the thing that's kind of aided that has better understanding the genomic landscape of prostate cancer. So there's a paper on the molecular taxonomy of primary prostate cancer, which is primarily TCGA data. Then there's also a recent report on the clinical genomics of advanced prostate cancer. And the upshot of all this is that although the primary disease is fairly bland, in advanced disease, you tend to see either amplification or mutation of the androgen receptor, or you see problems with DNA repair, or there is amplification of the PI3 kinase pathway, and more recently, getting better defined are epigenetic abnormalities in prostate cancer. As an update of this, there was a recent paper in Nature Genetics, once again comparing primary tumors with CRPC, and as you can see, most of the abnormalities are right-shifted, and just meaning they're primarily present in CRPC, and most therapeutics now is targeted, or newer therapeutics is looking at exploiting, targeting DNA repair or targeting the PI3 kinase pathway. There's also a lot of interest in RB. There's a lot of interest in epigenetic abnormalities, and then changes in the androgen receptor. So again, the theme really here is the primary disease is fairly bland from a molecular perspective, but advanced disease, it tends to be very heterogeneous. So talking about DNA repair, which is probably the furthest ahead. So there was a recent paper in the New England Journal where they looked at DNA repair abnormalities in men with metastatic prostate cancer. Now these are primarily or only germline mutations, and surprisingly, at least in this study, about 10 to 11% of the patients had abnormalities in DNA repair. The bulk of them are in BRCA2, but there are also smaller percentages in BRCA1, CHEK2, and ATM, and then in a host of other DNA repair genes, but at a much more smaller percentage. So if you look at DNA repair abnormalities across the spectrum, in primary disease, it's less than 1 to 2%. And again, those would be germline. In metastatic disease, germline are about 10 to 11%. We don't have an accurate estimate of somatic mutations in this setting. And in the CRPC setting, DNA repair abnormalities are 20 to 25%, and that's a combination of germline and somatic. So there have been a number of studies trying to exploit this. This again was another abstract from this ASCO, where there was a phase 2 study combining abiraterone, which is again an androgen biosynthesis inhibitor, with olaparib versus abiraterone alone. The primary endpoint was progression-free survival. That was improved, but there was no difference in overall survival. A phase 3 study is planned because clearly this was a phase 2 and not adequately powered to study that. The notion here is that abiraterone induces breaks in DNA repair, and hopefully and presumably that synergizes with olaparib, which is a PARP inhibitor. About a month ago, there's another trial that's going on with another agent called rucaparib, and based on preliminary data from that, so that is rucaparib alone in patients with known DNA repair abnormalities, that has gotten breakthrough designation because of a benefit to using rucaparib in that setting. But that's still just a breakthrough designation. The other thing people have also looked at is trying to biopsy patients with CRPC and see what abnormalities they find. The striking thing here was when you do a bone biopsy, and so this is the results from 220 patients who were biopsied, 118 of them had bone only. Biopsying bone is a problem because even out of the 220, only 124 were evaluable. And even in good hands, when you do a bone biopsy, probably only 40 to 50% are evaluable. And again, there were like 9 or 10 institutions which participated in that study, and at least in 3 of them, the information from bone biopsy that was usable was only in about 10 to 15% patients. So I think before we do bone biopsies, we just have to be cautious. The interesting thing here was the histology of these 120 evaluable patients. 13% had classic small cell features. 26% had this so-called intermediate atypical phenotype. We don't quite know what it is, but at least prognostically they do poorly. And then 26% of biopsies had distinct but mixed populations. So because of this, there are a number of different terminologies that have cropped up. So small cell is straightforward, neuroendocrine is reasonably straightforward, but what it implies is that it's not pure small cell. Then there's something called the atypical intermediate, there's something called anaplastic, there's something called an aggressive variant, And clearly, to better define this, we'll need to get a better snapshot of them at a molecular perspective. Now, there are efforts to look at circulating DNA to see whether you can pick up these molecular abnormalities in circulating DNA. And so far, the concordance between circulating DNA and actual biopsies is only about 60 to 70%. And most of these comments primarily apply to defects in DNA repair. So again, so some people have tried to define these populations better. So we talked about the small cell histology. In newly diagnosed, it's less than 1%. But as you would expect, in the castration-resistant setting, it's up to 8%. The other thing that also keeps on cropping up are defects in P53, RB1, and P10. And they also, it's a fairly high percentage in newly diagnosed, but it doubles in the castration-resistant setting. And the same is true for primary resistance to androgen signaling inhibitors. Now, P53, RB, and P10, I mean, this is interesting, and there's a lot of work has been done on this primarily at Roswell. And what we know is that if you knock out all these three genes in a mouse model, you upregulate EZH2, which is an epigenetic protein. It's responsible for histone methylation, and in effect, silencing the genes, and you get a neuroendocrine phenotype. Most of this work is by David Goodrich, who's a scientist here. The other advance on the basic science side is that as you treat prostate cancer, you wind up creating two populations of cells. So you have a progenitor cell pool, which is androgen receptor low, doesn't express PSA, and you have another population which is androgen receptor high and also expresses PSA. Now, the striking thing here is this population of AR low cells is present at the onset. Again, we don't quite know whether it's only high-risk disease, all disease, but it's present in the beginning. And as you treat, you primarily block this population, so preferentially this population expands. So the notion here is that we probably need to co-target not only the androgen receptor, but also these other populations which reach to more refractory subtypes. So at Roswell, we potentially have 3 trials starting early next year. So one is based on targeting an AR low population, which overexpresses BCL2, and this is based on the work of Dean Tang. Then the epigenetic pathways I already mentioned, targeting EZH2, in addition to the AR, and this is based on David Goodrich's work. And then there's also some evidence that you can target immunologically, or you can better target prostate cancer immunologically if you do appropriate chemokine modulation, and that's based on the work of Pavel Kalinski. So I guess no talk in oncology is complete today without talking about checkpoint inhibitors. They have been tested in prostate. Actually, this is a well-designed study, looking at different groups. The bottom line here is that in prostate cancer, response rates with single-agent checkpoint inhibitors are probably less than 10%. The populations that have been studied are patients with soft tissue disease, stratified by PD-L1 positivity or PD-L1 negativity, patients with bone metastasis independent of PD-L1 status for obvious reasons. And recently at ASCO, they reported on these 3 cohorts. And like I said, the response rates were less than 10%, probably slightly more in the patients with bone metastasis. In aggregate, this was about 250 patients. I think there were 130 in cohort 1, 60 in this, 60 in this, but my numbers may be a little off. But anyway, in aggregate, about 250 patients. We are still waiting to hear on the results from patients with early disease. So this is CRPC. This is metastatic CRPC, which has not been heavily pretreated. They've only failed 1 AR-targeted therapy, and the results on this are awaited. So I think the reason this study is going to be interesting is, and again, this was reported in abstract form this year, the only set of patients so far who predictably have a response are patients who are MSI high, which is about 1% of patients with prostate cancer. This is being done with a lot of biomarker work, and maybe this will give us some interesting clues. as to who are the patients with prostate cancer who may respond to checkpoint inhibition. Perhaps we need chemokine modulation before we can turn a cold tumor into a hot tumor. So all those questions, all that is ongoing work. But at the same time, I do think we need to keep, the finances in mind. The cost of pemrose for 1 year is about $150,000. So probably doing a biomarker non-stratified approach is probably not the way to go, given that its response rates are less than 10%. So this is finally my down-to-earth slide. We have all these wonderful improvements in care for men with CRPC, but I think as a community, we probably don't do a very good job of managing the side effects of androgen deprivation therapy. Be it the sexual side effects, be it the metabolic ones, maybe be it the psychological ones. I think there's a lot we need to do here as a community to improve the care of men with either metastatic or castrate-resistant prostate cancer who are essentially going to have lifelong castration. So in the remaining time, just want to move on to bladder and renal cancer, and I'm primarily going to focus on the abstracts from 2018. So the main abstract that was discussed for bladder cancer was a phase 2 study of erdafitinib, which is a FGFR inhibitor. If you look at the incidence of FGFR alterations, in metastatic TCC, it's about 15 to 20%. And in fact, in non-muscle invasive bladder cancer, it's about 40 to 70%. This particular study, they looked at different doses, and finally they settled on regimen 3, which is 8 milligrams a day. And that was primarily based on, if you look at response rates, they were highest at the 8 milligram dose with a 42% response rate. Now, a lot of these patients had failed both chemotherapy as well as checkpoint inhibitor therapy. But remember, this was a biomarker-driven trial, so some of the patients had only failed chemotherapy. So it's a mixed bag. I think a 52% response rate is encouraging. Probably what's even better is survival at 1 year, because once somebody has failed, first or second line treatment in metastatic TCC, median survival is typically 6 to 7 months, so 57% survival at 1 year is a significant improvement. And progression-free survival on this was 6 months, and overall survival at 1 was 13 months. So I think this is encouraging data, and this is now the basis of a phase 3 biomarker-driven trial, both in checkpoint inhibitor naive patients, as well as those who have failed, as long as they have FGFR alterations. There is significant toxicity, particularly there is concern about ocular events and central serous retinopathy. So clearly this will be important as we go forward in the phase 3 trial. The other drug which is definitely worthy of mention is enfortumab vedotin, and basically this is an antibody to Nectin-4, which is pretty universally expressed on TCC, linked to a linker and then linked to a spindle poison or a mitotic poison. So again, it's the anti-Nectin-4 antibody with a linker conjugated to this cytotoxic agent. And the impressive thing about this study was, again, if you just hone in onto the response rates, it's like 40% in the group that had prior checkpoint inhibitor therapy, 43% in the checkpoint inhibitor naive category, and 39% of the patients with liver metastasis. And all these patients had also failed chemotherapy. So I think in the third line setting, 40% and 39% is again impressive. And again, there is a phase 3 trial going on of this compound as well. So if you look at urothelial cancer in 2018, and again, just jumping straight to the metastatic side, clearly when patients are, they have good renal function and they're cisplatin eligible, everybody needs to see cisplatin-based chemotherapy, be it gemcitabine or cisplatin, or be it dose-dense MVAC. So I think there is absolutely no disagreement on that. In the cisplatin ineligible patients, either because of renal function or neuropathy or autotoxicity, I think there is a toss-up between either gemcitabine carboplatin or atezolizumab and pembrolizumab. I think there's a recent FDA guidance that for patients who are low PD-L1, we probably ought to be going with chemotherapy. If they are PD-L1 high, we should be going with one of the checkpoint inhibitors. So once again, the only two first-line checkpoint inhibitors that are approved are atezo and pembro, and there are 5 of them approved in the second-line setting. This is the FDA guidance that I spoke about, and I think this was based on the fact that in 2 frontline studies, what they found was patients receiving either pembro or atezo, if they had low PD-L1 levels, the survival was worse, and hence the guidance to do gem carbo in that setting. This is just a snapshot of the 5 different checkpoint inhibitors approved for in urothelial cancer, in metastatic TCC. I think the confusing thing here is how do you look at PD-L1 and where do you look at it? Should it be in the immune cells and the T cells, just the immune cells, just the T cells, both here again, T cells alone? So I think this is something which is still being worked out. It can vary with the stage of the disease. It can vary in the setting as to whether or not it's predictive of response. And at least in the first-line setting, the 2 drugs that are approved are atezo and pembro. And in this setting, so this is the last column here. So this is PD-L1 positive cells, or this is, PD-L1 high, PD-L1 low, and these are the response rates. They do seem to matter depending on PD-L1 status. Again, first line, not second line. And the same is sort of true for atezo, but not completely true. Strangely enough, with atezo, even in second line, this again being PD-L1 high, PD-L1 low, it seemed to be predictive, but if you now move on to pembro, it's not. So again, this is something which is evolving, but at least first line TCC, cisplatin ineligible PD-L1 status ought to be checked to determine or direct therapy. There's also a lot of interest in DNA repair genes in bladder cancer, particularly in the neoadjuvant setting. And again, the notion here being that patients who have abnormalities in DNA repair are going to be better responders to cisplatin-based chemotherapy. Based on this, there's actually a trial that is just being started through SWOG, where if you have, in the neoadjuvant setting, where if you have a CR with chemotherapy, patients will be randomized to either a cystectomy or not, provided they have abnormalities in DNA repair. So getting a CR without abnormalities in DNA repair does not qualify for a non-cystectomy, but if you do have abnormalities in DNA repair, you have a complete response with chemotherapy, then patients will be randomized to cystectomy or not. So that trial is just starting. Probably even more important is upper tract TCC, where the incidence of DNA repair or DNA disrepair is close to 30%, and primarily in the mismatch repair proteins. And again, this would be a subset who would respond better to checkpoint inhibitors. So at least as of today, the only setting checkpoint inhibitors are approved in TCCs in the metastatic setting. In early disease, it's still being investigated. Early meaning muscle invasive. So conclusions for urothelial cancer for 2018, the standard of care for frontline therapy remains cisplatin-based chemotherapy. PD-L1-based therapy is primarily treatment option for second line, and frontline cisplatin ineligible patients who are PD-L1 high. There are a variety of targeted therapies in early or late stage development, and an FGFR inhibitor seems to be promising, and again, in patients who are FGFR positive, and a phase 3 trial is underway. Moving on to kidney cancer, these were the 3 abstracts that were discussed. The first one was single agent pembro in the frontline setting. Patient reported outcomes in the context of a combination of checkpoint inhibitor and bevacizumab, which is an anti-VEGF agent. and then the role of a cyclone reductive nephrectomy versus systemic therapy in metastatic kidney cancer. So for clear cell kidney cancer, these are the current recommendations for first-line therapy. So in favorable risk disease, it's either sunitinib or pazopanib, and the others are ipi/nivo, and then these other options are listed here. In the intermediate and poor risk categories, it's either ipi/nivo or cabozantinib, and the others that are recommended also are sunitinib or pazopanib. Just quickly, what is good, intermediate, and poor risk? Currently, what we use in the metastatic setting are the Heng criteria, which is really an expanded memorial criteria, and they take into account the performance status. Probably the single most important one is time to initiation of systemic therapy. So if it's less than 12 months from diagnosis, I mean, those people uniformly do poorly. And if it's more than 12 months, it's more favorable. And then there are things like hemoglobin, the white count, the platelet count, and I think I mentioned the performance status already. So what we know is favorable is having none of these risk factors, intermediate is 1 to 2, and poor is 3 to 5, and you can pretty much segregate patients into how they're going to respond depending on these criteria. There are a number of combinations that are currently being tested, and some of them in phase 3, some of them that have been resulted, but not yet approved in the frontline setting. So the ones I want to mention are pembrose and axitinib, pembrose and levantinib, then the other one is avelumab and axitinib. And again, as you can see, the response rates are pretty high, but we don't have mature data on survival. Probably the combination that's furthest ahead is atezo and bevacizumab, 454 patient trial. Surprisingly, the response rate was lower, but clearly it's survival that's going to matter. And the comparator with all this is sunitinib. This is the ipi/nivo, data the study that I mentioned. 425 patients, sunitinib 461. Progression-free survival on this was about 8 months. On this it was 11 months. Survival here was about 25 months. Survival on this has not yet been reached. So based on that, ipi/nivo was approved in the first line for poor risk. The other thing to keep in mind is the incidence of treatment discontinuation due to AEs. So axitinib is 5%, atezo and bev 12%, but as you get into these combinations, it's more close to 20%. Just something to bear in mind. This is the pemrose study, single agent pemrose in the first line. 110 patients with clear cell, 164 in the non-clear cell. The data reported is only in the clear cell group. Of these 110 patients, 52% were intermediate risk, 17% poor risk, so 60% of the patients had high-risk disease. They also stratified them by PD-L1 status, using 1 as a cutoff for the composite score, and again, evenly distributed between PD-L1 high and PD-L1 low. And surprisingly, the response rate for single-agent pembrose was pretty high. It was 38%. But with the caveat, it's a small study, it's only 110 patients, and we don't have survival data. The other interesting thing that panned out was, if you look at the composite score, if that was high, the CR rate went up to 6.5%, whereas none with the composite score was less than 1, and the response rates also seem to follow that. Now remember, in renal cell, there's never been any correlation between response, or at least reported correlation, between PD-L1 status and response. In fact, in the second-line Nivo study, the correlation was negative. So in the first-line pembrose, I think these are intriguing data. How they pan out kind of remains to be seen. Progression-free survival on this was 8.7 months, which is very similar to sunitinib, and clearly overall survival is awaited. So again, it may have a role, but at this point it's unclear. And so if you look at frontline therapy with checkpoint inhibitors, we have 3 single-agent studies, but again, I think in poor and intermediate risk, none of these really supplant ipi/nivo, though the data on pembrose is intriguing. So the take-home message was monotherapy has a favorable toxicity profile. PD-L1 status may matter. Duration of response is comparable to sunitinib, but clearly we need to wait for the overall survival data, and it does not supplant ipi/nivo in the intermediate and poor risk settings. So very quickly, this is the frontline combination of a checkpoint inhibitor and an anti-VEGF, which is the furthest ahead. And again, the comparator is sunitinib. And I think the main point here really was the toxicity profile was much, much favorable. It's too early to talk about response rates since we don't have survival data and whether or not this it'll supplant ipi/nivo or be recommended in the same space. This, again, mainly just talks about this favorable symptom profile. And again, the take-home message, patient-reported outcomes are much more favorable for the combination. And the true comparator for this combination may actually be ipi/nivo or cabo. And again, the efficacy data is promising but needs to mature. And finally, the last abstract I want to talk about is the Carbina study, which compared nephrectomy followed by sunitinib versus sunitinib alone in the metastatic setting. So remember, there's always been this debate, do you take the kidney out or not in metastatic disease? Typically what we do is we do tend to push for that, at least in patients with a good performance status. This kind of study took that further, and they actually found no difference. So this was a non-inferiority study, and at least this study reported it did not seem to matter. So this may be one of the first studies which is dinging a nephrectomy in the metastatic setting. But I think the take-home on this was sunitinib alone is non-inferior to nephrectomy, followed by sunitinib. It may be true, but it's not surprising based on data, retrospective data for intermediate and poor risk patients. So anyway, we don't recommend a nephrectomy or for that. The other thing to keep in mind is 40 patients in the nephrectomy arm did not receive sunitinib, 16 were not operated, and 38 on the systemic treatment arm did not undergo salvage nephrectomy. Underwent salvage nephrectomy. So again, that may cloud the data as well. So again, I think the bottom line here is that most patients in the US undergo nephrectomy only if they are good risk. We don't really recommend it for poor risk. I admit that intermediate risk is a toss-up. So I think this is again an intriguing study, and I think it possibly will influence behavior, primarily in the intermediate risk group. So with that, I'll end the talk and I'll kind of go back to the questions. The post-test, so this is back to the patient with prostate cancer with high-risk Gleason 9 disease, fairly low PSA, high volume skeletal mets, low PSA in proportion to tumor burden, and also with a liver lesion. So I don't know if anybody has any thoughts now. Okay, we are still the same? Okay, so I think the correct answer here probably would be ADT and docetaxel. You need to start treatment. I think it's good to do a liver biopsy, but it's not going to change treatment in frontline. You could either go with ADT docetaxel or ADT ABI. I think both are valid, but just given the disproportion between the PSA and the tumor burden, there may be a slightly more compelling reason for chemotherapy. But I think either ADT dosi or ADT ABI would have been okay, but definitely not the liver biopsy. Okay. Second one, this was first line treatment for metastatic TCC in patients with cisplatin ineligible disease. And I think most of you got this right. Whether you go with gemcarbo or whether you go with pemro, you need to check the PD-L1 status first. And once again, pemro and atezo are the only two checkpoint inhibitors approved in the first line setting. And the only one with level 1 data in the second line setting is pemro. And then the final question is frontline treatment for poor risk clear cell kidney cancer. And the choices were sunitinib, pazopanib, pembro, axitinib, Lenviva, everolimus, ipi/nivo, and nivo. And Okay, so yeah, I think most of you got that right. So I guess the take home for me is I need to do a better job of educating people on metastatic prostate cancer. Thank you. I'm happy to take questions.
Thank you very much.